by Dr. Sandra Blome, who is currently the head of the German National Reference Laboratory for ASF and CSF at the Frederick Loeffler Institute. Sandra has been at FLI for the past 12 years, where her research has focused on studies on pathogenesis of viral infections, diseases with particular emphasis on virus-host interaction and diagnostics vaccine development. Sandra will now give her seminar an update on diagnostics for African swine fever.
So, hello everybody, I hope you can hear me. So I will give you an update on diagnostic challenges, but hearing yesterday's webinars, I decided to restructure my talk a bit because I heard a lot of very basic questions, and I decided to give you an overview and also to discuss then the challenges we perceive. Why do we need laboratory diagnosis for African swine fever? There is definitely a problem in a clinical diagnosis. So differentiation of African and classical swine fever is mainly impossible based on clinical signs alone. And the same is probably true for several other differential diagnoses. I just brought you this picture. On the left-hand side, you see domestic fattening pigs at the 7 days post-infection with the highly virulent ASF strain Armenia. So this is the one that is causing our headache. And on the right-hand side, you see domestic pigs and also some wild boar at the 7th day post-inoculation with a highly virulent CSF strain. The only thing that you see is that the animals are sick. They are having fever, they shiver, they don't eat, but in the end, it could be any other disease. So in the end, laboratory diagnosis and confirmation is a mandatory thing. What possibilities do we have to detect the virus? First, what we call direct methods will detect the pathogen itself. So you see, African swine fever is a really beautiful virus, but it is very complex. And we can detect either the infectious virus, some viral antigens, or also the viral genome. So it's in the end the sequencing or the sequence. Then, of course, the host will react to the virus, and we can also detect the responses of our hosts, so antibody responses, and in some cases also T-cell responses. So one of the crucial things, and also one of our challenges, is whom to sample. We definitely need somebody to raise suspicion and to take the right samples from the right animal at the right time. And of course, somebody should also send the sample in an appropriate way. Sometimes I receive samples that are in various stages of decay. This is not a very nice sample. Some tests will still work, but there are others they won't. Let's have a look at the first picture. So on the left corner, in the upper corner, there is a group of pigs, 5 pigs. All have been inoculated, but only 4 are infected. If you see this animal sitting there in the middle, this pig will probably come to you eating your boots. It's easy to get a sample, but this animal is definitely not the right one to sample. At that time point, it was completely negative. And if you would have taken only this animal, you would have done the wrong diagnosis. So remember, ASF is not necessarily a highly contagious disease. So it does not spread like hell. So you have to sample the risky ones.
Spread like what? Hell.
So the risky ones are the ones with fever. They show runting, just the sick ones. Let's have a look at the right-hand side in the lower corner. So in the pigs that are in the back of the picture. The one that is on the right side, this pig will probably not stand up. It's lying in the corner of the pen. Yes, it's the one that you have to go, the sample, and you have to go there. It may be deep in the shed, but this is the right one. It has high fever. It looks like a moribund animal, and it also has a high viral load. In this case, you detect the disease. So keep in mind, the best test cannot perform with inappropriate samples. And if you take the wrong animal, this can be the case. In the lower corner, I put a picture that gives you some headache. These animals have high fever. It's 18 days post-infection, but they look rather healthy. They all went to you, and you have to make a choice. In this case, you just have to do random sampling. These animals have an acute transient infection, and these animals have virus and antibodies. So if you try to sample them, you will find out that they at least saw the virus. What samples could we take? If you sample sick or fallen animals, you are in the end targeting direct methods. In this case, we would like to have EDTA blood samples. Please avoid heparin samples if PCR is intended. Heparin is a strong inhibitor of PCR reactions, and don't send this if you like to do a PCR. There's also a possibility to use serum. I will come back to this later. We have to be very careful because in the very early and late phases of infection, serum is much less suitable than EDTA blood. The genome load is low in these cases. Another good sample is a spleen. Spleen is very high or has high viral loads, and if you can get it, it's one of the most suitable samples. There are also other tissues that you can send. It's lymph nodes, the tonsil, lung, kidney. So it's a systemic disease. So in the end, I will find the virus in most tissues. There is actually, in the end, recommendation to use bone marrow for white boar if they are in a better shape. The problem is that bone marrow is not a good sample if you sample the fatty bone marrow. You really need the red one to have good diagnosis. So whenever you can find something else, please avoid to send us, in the end, bones with the bone marrow. Then, of course, you can also do the indirect methods. They are mainly used for screening purposes, for monitoring, looking in affected holdings to give you an idea about the age of the infection. In this case, serum, plasma, and to a certain extent also meat juice and whole blood can be used for some applications. One important message is if the first choice sample is not possible, just talk to the lab. There is a lot of options in most of the laboratories, but please ask them what they can handle. What are the methods we are going to use? If we want to detect the infectious virus, there's a possibility to isolate the virus mainly on primary cells. So in the end, on macrophages derived from bone marrow, from lung, or from blood. And we usually do hemoadsorption assays. But as some of the isolates will not do this, they don't have an hemoadsorption capacity, we can also stain macrophages and look with immunofluorescence. There are still some countries that do bioassays, but in terms of animal welfare, we should probably skip bioassays as much as possible. If we want to detect the viral antigen, there is a possibility to stain cryosections. There is an antigen ELISA, but please keep in mind that this is not very sensitive, and it also has problems if the animal has antibodies. And then we have now also the possibility to use lateral flow assays, but again, I will come back to them. They have a low sensitivity. To detect viral genome, we can use different approaches of PCR, gel-based PCR, real-time PCR. I put this in red and bold because this is the main method if we talk about field diagnostics or diagnostic from field. Then sequencing, some other applications like direct PCR and isothermal methods. And antibody detection, the first line of defense is an ELISA, but we also do for confirmatory reasons, indirect immunoperoxidase test, indirect fluorescence antibody tests, immunoblots, and also lateral flow assays. We are not just dealing with something that where we don't have rules. There are a lot of rules, and on a global scale, you can just see the OIE. Just see this link below. There you will find the terrestrial manual, and you will find all information there. So in the end, if you look at this broad range of possibilities, we do not really have a challenge in diagnostic tests. ASF has a lot of problems, but diagnostics is not the worst. Look at the real-time PCR. Real-time PCR has a high sensitivity and specificity, and it can be used with a large variety of sample matrices. Reliable detection is possible from roughly 3 to 4 days post-infection, and it's also possible very long, so roughly 70 to 90 days. If you look at some drawbacks, it's rather expensive and requires good equipment. We have now commercial tests available, and most are suitable. This is an advantage. These tests are really validated, and often they are licensed. So it's quite good to use them also in labs that have not been accredited or they are in the process of accreditation. For these tests, nucleic acid extraction is needed, and this can be a very crucial point. The nucleic acid extraction can be done manually or automated. So in the end, PCR is suitable for large-scale testing, and also extraction can be done large-scale. You should prefer tests with an internal control. It can be either heterologous or endogenous, but these internal controls secure reliability of negative results. The quality control is towards inhibitors of PCR and or the sample quality. But high sensitivity also means that you have a higher risk of contamination. You should always check plausibility of results and have a backup system available in the lab. Backup systems should target another genomic region and are only used for confirmatory testing. If you're dealing or you're working in the lab, keep your fingers off these confirmatory tests. You only take them off the fridge when you have a problem. Just to give you an example, I heard yesterday how to interpret these CQ values. If you have a sample with a high viral load, you have a low threshold cycle because the fluorescence is rising soon. So if you have then a low viral load, it's the other way around, you have a high threshold cycle. If you have a PCR with a control, for a positive sample, you have a fluorescent signal for the target, but the internal control can be negative. This is because we restrict the PCR resources. So the primer concentrations are much lower for the internal control. The target is served first. So if there's a lot of target, the internal control can be negative. It does not have to, but it can. Negative samples should have no signal for the target, but a positive signal for the internal control. An invalid sample with a lot of inhibitors will have no signal. I just put it as a panel on the right side. You see the red one is the positive one with the blue curve for the target, a green curve for the control. So both worked in this case. Then you have the green box over there. There you only have the internal control, no target, it's a negative sample. And you have one with just baseline calling. This is an invalid sample. It could be inhibitors, it could be that you made a mistake, but this one is invalid. The real-time PCR is in principle quantifiable, so quantification is possible using standards. I just put in the middle an example of the standard curve. So you could find out how many genome copies are in your sample. The question is for animal disease control, this is not really important. Even a few copies will render the animal positive. So it is mainly for research purposes and for the purpose of trials. The antibody ELISA is the other first line of defense. Detection of an antigen-antibody reaction is the case with labeled antibodies. The labeling is done with an enzyme. It's often horseradish peroxidase, and we measure optical density at a defined wavelength later to define if a sample is positive or negative. Despite the fact that we get some semi-quantitative results, it's a rather qualitative outcome. These commercial tests that are available are usually fit for purpose, but they show a moderate sensitivity and specificity, and for that reason, confirmatory testing is beneficial. Most tests work with serum and plasma. Some have also been validated for filter papers, swab punches, and also meat juice. in the end, you have to check what they are meant for, and they can give reliable results. The detection is usually from roughly 10 days post-infection, and it lasts for at least several months. It's rather low tech, but I had already some problems, not only in Africa, but also in Balkan states, that the water quality was low, and then we had a lot of problems with the buffers, and the optical instruments can be crucial. If they have not been validated for 30 years, there is definitely a problem with the reliability of the results. There are indirect and competitive formats on the market, and these systems use different antigens. This also means do not expect in all cases to have the same result. Check plausibility and also check what antigens they are using. An important thing is, what can we expect to detect? Whenever you choose a sample or test priority, keep the infection biology and pathogenesis in mind. There was a lot of discussion when the first antibody positive wild boar were detected in Poland. But what does it mean? It only means that the animals survive longer than 10 days. There is no really predictive value to it. You also should keep in mind that ASF is originally an arbovirus. So if you want to detect the virus, blood contains the highest viral loads, and 1 drop of blood is much more infectious than loads of secretions. Viremia is rather long, even in the convalescent animals, and a lot of discussions about carriers and so on is rather a semantic issue. What we can say is that most of our animals, at least all animals in my hands, recovered or died, but the phase of detection can be rather long. You saw 90 days. If you want to do the first line of defense, so early warning, choose a sick pig to obtain initial samples. And keep in mind, viral genome is not infectious virus. So if you find a few genome copies on water or wherever, this does not mean it's highly infectious. I brought you some figures from recent animal trials. Just look at the right-hand side. There is the qPCR results of EDTA blood. And on the top, you will find the percentage of positivity. You see that between day 7 and 40, all animals were positive for viral genome. And then the percent positivity decreased to roughly 50% until day 90. Day 90 is rather long, but we also followed the animals further on, and there was no detection at 164 days post-infection. So these animals can still recover completely. And on the right-hand side, you see the comparison of EDTA or the qPCR from EDTA blood and virus isolation, in this case from sera. And you see that the virus was gone by day 60, at least 63, but the viral genome was still detectable. So whenever you look at the test results, keep this in mind that this is not the same. I brought you some slides also from a very recent animal trial to show you that already at day 4, we have a reliable detection from blood, but also from quite a lot of tissues. So in the end, roughly day 3, day 4, this is when we can detect the viral genome. Look at alternative samples. Shedding with secretions and excretions is rather low, and we have to discuss if the suitability of matrices is always the case. Swabs may not help with small holdings or individual animals because this can really give the false reactions, but they may be fit for purpose in large holdings. If you look for a herd-based result or when sampling dead animals, it can be that it is fit for purpose. There is actually some studies from Belgium where they show that nasal swabs from fallen wild boar give very reliable results. This contrasts a bit what I show here, but in the end, if an animal is dead and you have a lot of blood everywhere, this is not really a problem to detect. Then the viral genome from swabs. And it's always the case, hemorrhagic signs will aid detection, so bloody fecal or oropharyngeal swabs will also be possible. In the end, when you talk about what samples to take, you should first do the optimal. But if the optimal is not possible under your circumstances, there's a lot of options that can still give you some reliable results. Look at the antibodies. Antibodies appear roughly between days 7 and 14 post-infection. But as I already mentioned, they do not have predictive value for final disease outcome. So it is not a problem to find a dead wild boar that has both antibodies and viral genome. It only tells you that this animal survived longer than roughly 10 days. And for this reason, the antibodies will tell you about the age of infection and can give you very valuable hints about the high-risk period. And they can also detect infections with strains of lower virulence that probably even went unnoticed. Most of the cases that we have at the moment with genotype 2 strains are highly virulent cases. But still, you have seen these animals that were sick but were not showing too many signs. This kind of things can go unnoticed, and in these cases, you will find antibodies. I just wanted to go back to sample matrices a bit. This was a recent trial that we did, and we compared EDTA blood and serum in qPCR. In the end, serum is a very nice sample matrix because you can use it in any of your tests. You can use it for the serology, you can use it for virus detection. It's a clean sample if you are lucky for the virus isolation. But have a look at the graph. On the left-hand side, it's 4 days post-infection, and we compare the viral loads in genome copies for EDTA blood and serum. And there we see a huge difference. Just look at this blue animal on the left-hand side. For EDTA blood, it's 400 genome copies. It's already low, but look at the serum, it only has 3 genome copies. And if you then consider pooling, you may miss this early phase of infection. So keep in mind, it's a disease that can be transmitted by ticks. The virus is attaching to erythrocytes. And in the initial phase and later phase, the serum contains much less viral genome than EDTA blood or whole blood with the erythrocytes. You see on day 7, all the animals were sick. There's no problem in detection also in serum samples. So when you use samples from sick animals, it's probably not a problem. If you are going to test animals, for example, in contact holdings, be aware of this problem and aware of these discrepancies. We often heard, we couldn't send you a sample because it was of bad quality. This is a bad excuse, actually. In the very beginning, we tried to do storage and sample quality testing or assessment. What we did is we used different matrices. In this case, it's German, so I will read it to you. It's blood, spleen, muscle, and feces. And we kept it for 1, 2, 3 months at different temperatures that you have available in the lab. It's the fridge, the freezer, and the incubator. And in the end, I just put there these red squares. For the blood at day 0, it was even lower in genome load than the sample that we took after 3 months at 37 degrees centigrade. So please don't tell me that the sample is too bad. It's usually a bad excuse. In Europe, we target the wild boar carcasses, and sampling is definitely not easy. If you ask the hunters to sample them, the rotten carcasses are smelly and to a certain degree disgusting. Some organs are not available anymore. If you look at these half taken or half eaten carcasses, the spleen is no longer there. Blood or decent fluid is not available, and some carcasses are just skeletons. Against this background, we tested a lot of alternative sampling methods. Our colleagues from the Netherlands have tested bone marrow in the end, how to get the bone marrow out of the bones. We have tested blood swabs, and I will share a bit of the results just to show you that it is sometimes a bit of creativity to find a way to still get decent samples. What we did is we used swabs that we could handle in the lab, and we used these swabs for both antibody and genome detection. To cut a long story short, you can say, okay, you lose a little bit of sensitivity, but we have a good correlation between our values of these genotube swabs and the EDTA blood. The same is true for the antibody detection. You can also use these swabs for other diseases if you do syndromic surveillance. And you always have to discuss fitness for purpose. Is it really a problem if you detect one white ball less in an affected region? Because there's not only one white ball showing the disease. So in the end, this is something you have to discuss with your risk managers, your veterinary services, but you should keep in mind that fitness for purpose is not always 100% sensitivity and specificity. You can combine to a certain extent these methods even with some point of care diagnostics. We just did it in the beginning for fun because we had the possibility, but it turned out to be much better than expected. We actually cut pieces from the swabs and used it in an ELISA that was licensed for the use with filter papers. And you see that you even have some doubtful cases that were doubtful in the ELISA that also give doubtful results on the lateral flow assay. In this case, it's a lateral flow assay for the detection of antibodies. Please keep it in mind. The antibody LFD is rather good. What about this point of care testing? Can we use it in the field? Antibody LFDs are quite sensitive and highly specific. But the problem is the target animals, the fallen animals, may not have antibodies because we are in early warning looking at passive surveillance. So they are rather nice, but maybe not the right choice. The antigen LFDs lack mostly sensitivity, but they are also specific. In our hands, sick pigs are usually detected under experimental conditions, but more data are needed to assess their suitability under field conditions. Dick Pfeiffer said yesterday in his presentation that we have to be open-minded and do not disregard this kind of options. In the end, we have to have more data to really say if they are fit for purpose, but definitely they will not detect all animals. There are also some field deployable genome detection methods that are under development and evaluation, and future will show their true value. There is one problem with these point of care tests. Who is going to test? And who is going to report to whom? And what is the impact of positive and also negative results? In my opinion, a positive result is, in the end, there's enough evidence that there is problem in the farm. But a negative result could still mean there's disease. So in the end, these animals have to be retested, at least if there was a suspicion based on clinical science. For Germany, this was, of course, my target. I have problems to see the application. If you give it to the farmer, what will he do? And how long will this test be in the shed before he uses it, and so on? So the quality assurance is a problem, and also the reporting of the results. But anyway, we have to be open-minded and also consider this kind of test systems. I was often asked, should and could we test meat and other matrices including crops, including whatever surfaces? We try to find a way, and in the end, there is no major problem with products that have retained their structure, and also salami with even additives, cheese, pepper, whatever. The question is rather, is it something we should do? Because in the end, we do not know the impact of these findings, and how would you follow it up? If you find somebody at the airport that is bringing a sausage and the sausage is positive, what does it tell you and what will you do? In the end, it's a rather expensive assay, and we have to also see what is the follow-up. In the end, if you really want to test it, there can be applications. We have found out that magnetic bead-based extraction methods are suitable for most matrices. There are inhibitors present at a lower level, but they do not exclude the diagnosis. So keep in mind what you will do with the results. But in the end, yeah, it's possible. Some words about quality and impact. As I said, the fully validated commercial tests can facilitate diagnosis. The labs should still do some verification with in-house samples at the national and regional lab. Actually, there is rather a problem with result interpretation than test performance. Whiteboard samples can be tested with all available test systems. However, the sample quality matters, but this is not a problem with whiteboard. It would be also a problem with domestic pigs. And please keep in mind that some discrepancies result just from biology. So please check the background, check plausibility, and do not just take figures for granted. The use of real-time PCRs should implement also an internal control to obtain reliable data, especially with poor samples. Do not forget the confirmatory testing. There are several labs that also do stone age testing, virus isolation, and so on. Please don't forget them. A PCR is a good thing, but you will never get the virus. Keep fitness for purpose in mind. In the end, it means that you do not have to detect a single genome copy under all circumstances. There are a lot of examples that you can control a disease with suboptimal test systems. If you look at bovine herpes virus, for example, some of the DIVA tests has a sensitivity mainly of 80% and also not really a good specificity, but it was helpful to control the disease. Keep also the impact and significance in mind. You cannot, for example, test a large batch of wheat for freedom from ASFV. If you have a positive result, it tells you something, but if you have a negative, you may have just taken the wrong sample. And there are some points of discussion. They are related to the pooling of samples. I am a strong defender of pooling. If you pool 5 samples, I think it can be done. But however, you have to establish workflows in your labs. And also there's a lot of questions about the point of care tests. So in the end, there's a bottom line. Tests will only generate results. You will get a lot of figures. But the challenge lies with sample choice and interpretation, especially interpretation. And this, in the end, needs experts and also experience. So please ask the peers, also ask some from other countries that had already ASF in previous decades. And please always do plausibility checks. The last slide, I want to share the beauty of diagnostic assays with you. This actually is an ham absorption assay. So it shows you that the virus grew in the samples. These are infected macrophages that collected more or less erythrocytes. They look a bit like raspberries. So you see, diagnostic assays can be very beautiful. And with this, I thank for your attention.
Thank you, Sandra. Does anyone have any questions? They can post them in the chat. Here we got one question. How much blood do you recommend to take for field samples?
It depends actually on how much you can get. For the PCR, I need 100 microliters. But in the end, if you can send 1 tube, we can do most of the assays. 1 tube meaning it's 7 to 9 milliliters.
What advice do you have for bone sampling?
The main problem with the bone sampling is really you should only apply it when there's a skeleton. if we have a bone, please take the femur. The femur was best suited to obtain bone marrow that we can still use in diagnostic assays. So this was the one. It's not so easy to open it, but it contained most virus. So in the end, this is what I would recommend, to use to send the whole bone to the lab. So in the end, you extract the bone, you put it in a suitable device and send it as it is to the lab, and the lab is going to open it. They don't love this, actually.
Sandra, are the qPCR commercial kits based on European strain sequence, or do they also include African strains?
This depends a bit on the manufacturer, but the ones that are licensed in my lab, they all also included African strains. They are detecting most strains that are available, at least through GenBank. There may be some exotic strains that will not be detected, but in the end, they have been tested also with these genotypes.
The commercial test for antibodies have moderate low sensitivity and specificity. If a positive on the competitive ELISA, what confirmation test do you recommend?
In my hands, we first use indirect immunoperoxidase assays, but we also use immunoblot. But the one that is the first line of confirmation is the immunoperoxidase test. It is true for most of the European countries.
Okay, how do you combine the diagnostics for ASF and CSF and other diseases?
In the end, what we do is we do extraction of nucleic acids. So we will have DNA and RNA, and we can then use it for both PCRs. And usually the samples are also suitable to do the serology for both. Actually, this was the reason why we, in the first go, went for the serum, because the confirmatory testing for CSF in our hands is a neutralization assay. That's a cell culture-based technique, and plasma is killing your cells. So this was the reason why we went for serum in the first place. It can be used, as I showed you, but it has some drawbacks.
What was the largest amount of time post-mortem, estimated number of days between death and sample collection you witnessed in a wild boar sample that tested positive?
It's difficult to tell, because to tell the age of a carcass is not so easy. Some of our colleagues, Carolina Probst and others, have tried to develop guidelines how old the carcass is that you see in the field, but the decay is very much dependent on ambient temperature, on humidity, and so on. So it is not so easy. But we know this for sure. There has been a study in Lithuania where they excavated in the end wild boar carcasses, and they were still positive for viral genome after 400 days. We talk about viral genome, we're not talking about virus.
Do SP-SE values vary between strains?
For some assays, it will probably do. For most of the PCR assays, I did not see too much of a difference. Some assays have some problems with genotype 9 and 10 viruses, but they still detect them. But there's a bit of a difference. For the antibody ELISA, I can only use what I have. I'm rather restricted in what I have done under experimental conditions. There I did not see problems, but I'm not sure about the whole African situation.
What is the best way to preserve tissue sample for virus isolation in case of no availability to a -80 freezer?
Without a freezer. I mean, if you use the spleen sample cooled, I have a rather nice chance to get the virus. So if you can keep it cool, it is at least a good opportunity. We did actually some field-based trials with one of my colleagues that accompanied the excavation. We tried to put it into PBS just to have it in a rather sterile liquid. In this case, we did not find the virus, but the sample looked well.
So this alternative to virus isolation using fresh PPIS.
Sorry, I did not get the question.
It says alternative to virus isolation using fresh, and that's PPIS. I'm not sure what that is. I don't know, Aruna, if you want to
Can you
clarify.
can you explain? Because
We'll skip that and see if we can get what that means. Which virus proteins do you suggest to use in antibody tests?
in the end, what we see is in the commercial assays there is in the end P72, the P30 and P62 as antigens. You know the nomenclature is not so easy, so it can be P73 or it can be P72, 32. But in the end, these are the main antigens. 54 is also one of the antigens. What I use in my hands is still a lot based on the P72. And as an earlier antigen, the P30.
Okay, alternative to using virus isolation, using fresh PPLS.
I don't know. I haven't compared, so I'm not completely sure. I'm sorry.
Do you think at some point you are going to be doing sequencing on the field using nanopore technology, MinI and Oxford Nanopore?
In the end, we have done some studies with MinION, and probably Jan will talk about it. If you really deploy it in the field, you should ask him. In the end, the best results were done on PCR products or on very or the long the long DNA. So if you don't have it too much fragmented, I could imagine that it is field deployable in the future, but you should ask Jan later.
We got our last question is, can you expand a little more into Pensign devices as an option for genome detection in the field? Also, any experience with nanopore sequencing?
My own experience in this direction is rather limited. So we have done our own studies with NALF detection. So using LAMP assays combined with nucleic acid lateral flow assays. It worked in principle. The main problem was that there was a problem with contamination. When you did it the one day, whatever you tested the next day was positive. So this was a serious problem. Probably you could overcome it, but it would mean reestablishing workflows and so on. In my hands, LAMP assays and other isothermal methods did not perform as good as the PCR. But I know that people that really went into details may have different opinions. But however, for me, it was not an option. There is now a lot of machines that are field deployable for PCR, including some from TetraCore, from Indical. There are different on the market now, and they give good results, even the ones that do direct PCR. But again, direct PCR is very contamination prone, and we have to be careful when interpreting the results. But I see some hope and future for this kind of assays.
Okay, thank you, Sandra. We're going to move on to our next speaker. It's an excellent talk. Thank you.
Thank you. So, bye.